I have Dr. Wayne McIlwraith, world-renowned veterinarian and head of the program at Colorado State University. And Dr. McIlwraith will be talking on joint trauma and osteoarthritis as a major cause of attrition in thoroughbred racing.
Thanks, Ed, and excuse me a minute while I change over to my computer. Larry and Rick have given perfect lead-ins to what I'm going to talk about. And it's interesting because seeing Rick's data there, when we started the study that was funded by the Grace and Jockey Club Research Foundation looking at biomarkers as a potential means of predicting fracture, I asked Rick as well as Vince Baker and Jeff Blair what they thought if we went for 10 months in California with thoroughbreds and training, what the attrition rate would be, because we needed to work that out so that we needed to figure that out so we had enough horses in the study. And they all estimated around 10%, maybe 15 at the most, and it turned out to be 80% attrition in that 10-month period, which I think it just goes to show why you've got to look at the numbers, because all of us have subjective feelings, and but those numbers are extremely sobering as far as the wastage goes. Okay. But the subject that I've been asked to talk about today is sort of a little bit more detailed, but certainly on the same theme, giving some details as to, first of all, how or a major cause of this wastage to us, and probably more importantly, and it'll probably help lead into what we're going to spend most of our time doing, is some ideas on how we might decrease that for the racing thoroughbred. So I sort of added just a little bit to the title, after joint trauma and osteoarthritis, a major cause of attrition in thoroughbred racehorses. What do we know and what can we do about it? So traumatic injury to bone and joints. The consensus is that all fractures in the athlete are pathologic fractures. This was first pointed out by Roy Poole, Sue Stover, Tim O'Brien at Davis, looking at fragments that have been removed arthroscopically, and I think it's led to more and more evidence that that fractures are pathologic in that there's diseased bone initially, and the cyclic trauma causes that diseased bone, and detecting that change before we get a fracture is key. So most fractures involve the subchondral bone, which is the bone immediately under the joint surface, under the cartilage, and many can be dealt with and careers continued, but some end careers and lives. And so this is sort of a summary. Rick alluded to the fact that we can do arthroscopic surgery. We certainly can return these horses back to normal. This is in the case of simple problems like osteochondral chip fragments. And then we can also, but others end careers, but the horses can still be saved. This is a picture of Michael Stout after Singspiel fractured his condyle just before the Breeders' Cup. And then last but not least, some end lives, as we well know, particularly the fractures that occur. Thanks, Ed, standing on my cord here. Particularly the fractures that occur in the sesamoid bones that are a number one reason for injuries requiring euthanasia. They all start as disease in the subchondral bone and in the cartilage of joints. So bone disease precedes fracture, and minor injury and inflammation precedes OA, and these are the two areas. They've certainly got overlap, but these are the two areas I want to sort of go through because of the significance in causing wastage. And this circle at the bottom just shows bone sclerosis, which is an early, we think, adaptive change, but when it becomes pathologic is an issue for us. So I just wanted to briefly review for you what a normal joint is. It's obviously critical for normal movement and activity. We have joint capsules holding the ends of the bone together. We have articular cartilage, which provides relatively frictionless motion. And then we have the synovial membrane, which is a thin lining inside the joint capsule that produces synovial fluid, and in particular, components that help lubricate the joint and provide normal movement, because we need frictionless motion. And so these chondrocytes here that we're showing synthesizing the components in the cartilage. When we're injecting joints, when we're treating joints with anti-inflammatory agents, what we're trying to do is suppress that inflammation that causes breakdown of these components in the cartilage. And so we've got two issues. One is early diagnosis and one is treatment. But an important factor is that the cells in the cartilage keep producing these components. And if we get something that disturbs the production of these components, and we call that catabolism, which implies breakdown of those components, and there's various substances that do that, this is what we're aiming at when we're treating most cases. We also have to promote anabolism, but the critical component for us as clinicians is to prevent that degradative process. So if we look at the joint as a whole, there's a number of components. We've got the bone, and of course a joint is basically an articulation of two ends of bone, or three parts of the bone. Cartilage around the bone, ligaments and tendons that help support the joint, fibrous joint capsule that's critical as far as holding those components together, and then the synovial membrane. Now, all of these tissues can get damaged, and that's what traumatic arthritis is about. We can get damage to the synovial membrane, and the inflammation of that produces these mediators that cause damage to the cartilage. We can get damage to the fibrous joint capsule, and inflammation of that is very, very difficult to treat. If we get loss of the structure of that, we get instability and we can lead to dislocation. Ligaments as well provide support. And of course, the final sort of pathway, or the stage where we're in major trouble, or our thoroughbreds are in major trouble, is when we get loss of the articular cartilage. And loss of articular cartilage, or the progressive degradation of the cartilage, is what we call osteoarthritis. Degenerative joint disease, same thing. Those terms are synonymous now. There used to be some semantics where they were different, but no longer. So the important thing to realize is that the joint is an organ. There's a number of ways that we can damage the tissue, and there's a number of ways where early diagnosis of that damage can potentially prevent OA, and it can potentially prevent fractures. But in these number of ways, you can really divide it into two possible pathways. And I like to sort of put it into abnormal forces on normal cartilage, or normal forces on abnormal or diseased cartilage. And this is a rather complicated diagram, but I'll just try and break it down quickly. Cyclic or athletic trauma can lead to two major events, or we simplify it by dividing it up into two things. You get inflammation of the soft tissue, traumatic synovitis and capsulitis, which just means inflammation of the synovial membrane and joint capsule. That is what we're chiefly treating when we're injecting joints intra-articularly or using some of the more systemic medications. Cyclic or athletic trauma equally well can lead to remodeling and microfracture or damage to the subchondral bone. If we have damage to the bone, we're going to lead to a loss of support to the cartilage, and we're going to have abnormal stresses on normal cartilage. Likewise, if we have an intra-articular fracture, developmental defects such as OCD in a young animal, loss of stability due to a tear or a fracture, we lead to abnormal stresses on normal cartilage, we get physical injury, and we can get breakdown of our cartilage. On the other hand, if we have chronic inflammation in the synovial membrane and joint capsule, we have enzymatic production of various mediators that lead to damaged cartilage, and then even normal stresses on that damaged cartilage will ultimately lead to osteoarthritis. So this is sort of a cartoon demonstrating in fast time the fact that we get degradation because of these factors. Not showing up very well, but we get degradation of the articular cartilage. So today, equine osteoarthritis can be considered as a group of disorders characterized by a common end stage, which is progressive deterioration of the articular cartilage, accompanied by changes of the bone and soft tissues of the joint. So we can divide it up. But the important factor is that if untreated satisfactorily, or if they're too severe, such as the initial injury, the intra-articular fracture, before we diagnose it, then we're going to get osteoarthritis, which is the progressive loss of articular cartilage, and this is what it looks like arthroscopically. We've lost that nice, smooth articular cartilage. And there's been a number of surveys or studies done on the attrition, but it's a figure that's thrown around a lot is that 60% of retirements come from this progressive loss of articular cartilage, osteoarthritis. So synovitis is the reason, and this is what it looks like if you look inside the joint with an arthroscope. It can be acute, it can be chronic, but the essential thing is it's producing these mediators that cause degradation of the cartilage, and of course there's immediate effects to the horse in that they cause pain and joint effusion or joint filling, which everybody recognizes. You can recognize clinically, and that creates a micro instability in that the normal joint is a minor vacuum, a small vacuum. And when you have the effusion, you have the loss of that that vacuum, and you create some instability there as well without rupturing any ligaments or joint capsule. So I don't think we'll have a test on this later, but there's a number of things that the important point is that when the veterinarian is treating inflammation, it's a critical part of prevention of that cartilage loss. And of course there's good drugs and bad drugs, and we haven't got time to talk about that today, but I think most of our medications now, we pay attention to this thing called interleukin-1, which is produced by synovial cells and also produced by the cartilage. And this, what it does is that it's at the top of the cascade of these various mediators. It acts on other cells to produce, release these metalloproteinases, and this is sort of a fast version of why our cartilage breaks down and why we need to treat that day-to-day inflammation, because these components are very important. Our cartilage has to be able to handle tensile forces and compressive forces. These bristle brush molecules are called proteoglycans. The side chains are glycosaminoglycans. You've probably heard of those because there's quite a lot of oral products that are administered these days to horses. Anyway, they provide the compressive strength because they're trapped within this sort of framework of the cartilage, these collagen fibers. So chronic inflammation breaks them both down. We have evidence now that interleukin-1 that I mentioned is the top of the cascade because it causes release of other mediators that cause destruction of the cartilage. And some work that Dave Frisbee and I did some years ago, prevention of OA with IRAP or interleukin-1 receptor antagonist, the normal antagonist, showed how interleukin-1, at least in equine osteoarthritis, is the critical mediator, and it's the mediator that we strive to prevent. This is a diagram of what we're talking about to prevent that inflammation. This is normal cartilage with the blue staining the proteoglycans we talked about. This is after a period of inflammation. There's no trauma, there's no instability, there's just inflammation, and we've got loss of the proteoglycans, which means we're losing the compressive strength, and we're starting to see a little bit of degradation at the surface. This is the earliest stage of fibrillation. What does this mean to us with the patient? This is an example of a very good horse, multiple grade 1 winner, that had a chip fragment here. On radiographs had nothing else, but when we go in there, the surface of the sesamoid bone was essentially bare of articular cartilage. So we get these surprises, and so I'll soon go into some of the things that we feel we've got or potentially have to diagnose that damage long before that particular situation develops. This is just one of the papers that iterated that they did a survey that showed that 60% of lameness problems in horses are related to osteoarthritis. And so that's why we have a myriad of treatments aimed at that. So the second major area where we are concerned about a joint being injured is in the subchondral bone, that bone beneath the articular cartilage. And this was a paper actually done, obviously it's a lot smaller than California, but it was a copycat of California from the Colorado breakdown program or injury program where all horses are post-mortemed at CSU. And showing that, you know, that the kind of change we get in the joints other than where the actual catastrophic injury occurs. And of course, there's been a lot of good work come out of Davis, and Sue's going to talk about that, but subchondral bone failure is a very critical part of what we do. And so this is just taking the bottom part of that large diagram I showed before and pointing out that we get physical damage, which takes away our framework. It's like the foundation of a house going, and the cartilage just physically does not have the support it should have. But also ongoing inflammation because of the disease in that bone leads to production of interleukin-1, which can then go into the cartilage and cause progressive loss of cartilage as well. So subchondral bone disease is a clinical entity. We can recognize it in certain locations on radiographs. This is a skyline radiograph of the carpus or the third carpal bone, and then we can see it arthroscopically. However, it occurs in a number of other areas, and there's no way that we can detect it with radiographs. Now, we treat it when we find it, and so this is just a case of a subchondral bone lesion. We're scraping out the diseased cartilage, or diseased bone in particular, because basically it's the bone disease that's our critical problem. This is what will eventually lead to a fracture, and this is just an example we're making. I know this is a large proclamation to make, but we've got accumulating evidence that microdamage will lead to fracture. This is a slab fracture, obviously at post-mortem, and we always notice, or we usually notice, a wedge of bone here that's diseased, and if you look at it histologically, it's essentially dead. And we think now that that acts as the initial focus for propagation of the slab fracture. So it all gets back to recognizing disease. This is work done by Chris Kalchak at our lab, showing that early microdamage can occur on a treadmill. It occurs frighteningly early in the subchondral bone. This is the bone cells. This is a micro crack. This is the opposite limb to a joint that had a catastrophic injury on a horse at Arapahoe Downs and Arapahoe Park, and you can see we've got a spectrum. We've got normal cartilage, necrosis of the bone, and sclerosis of the bone surrounding that. And so it's addressing this primary disease early that is one of the keys to preventing some of these injuries. And so this is a micro crack in the bone. This is the cartilage over the top, which is obviously intact. And this is diffuse, what we call micro damage. This is a micro crack, but this is diffuse damage in the bone underneath the cartilage. We also have shown that bone cells die with this exercise, and bone sclerosis is an early event. Now, this is a bit more of a gray area. We can see it on a radiograph. We can see it here. Development, sclerosis being scarring, increased density of bone. Does that lead to death and fracture? There's evidence supporting that, but it's an important area for early diagnosis. We also know that bone remodels in response to exercise. This is an exercised horse on a treadmill. Now, it's not showing very well, but very, very early the bone says, I'm not strong enough, and it's been well demonstrated by a number of people with buck shins and with stress fractures in the shin. The same thing happens in the bone, in the subchondral bone beneath the joint. So when do these changes in the bone become pathologic? It's an important question, but it's critical to us answering the question of how can we potentially decrease this disease, or at least recognize it early. So these are my list of areas for potential manipulation. Some of these have already been talked about. I'll go through them quickly. As far as possibilities for where we're going, and some of these I don't mention specifically in the next few slides. Track surface is going to be covered by Mick Peterson, and also Sue's going to talk about some of the work they've done with this. Obviously an important area for potentially being able to decrease injury. Conformation and selection, and of course, Dare, you mentioned the genetic word, but based on extrapolation from humans, there's probably no question that we will eventually know collagen defects that lead to potentiation of fracture or potential of individuals for fracture. Conformation has been shown to be a factor. Modification of training regimens, Sue will probably talk about that. Conditioning of the young musculoskeletal system. We've done some work in New Zealand where we started cantering foals at 3 weeks of age and showed that we could improve their articular cartilage, and we didn't cause any damage to those young individuals. Prevention and treatment of DOD, manipulation of those individuals. Effective treatment is important. Whether some of the manipulations help us or hinder us is open to question. Track surface we mentioned, and then the early diagnosis, which I want to show a few ways where potentially we can do that. So confirmation, there's been a paucity of objective data. This is a paper that Tina Anderson and I did in European thoroughbreds, looking at certain conformations that would, in fact, promote injury or increase the incident, were associated with an increased incidence of joint disease in fetlocks and carpal joints. This is just an example of a paper looking at a relationship between injury to the suspensory apparatus, exercise and horseshoes, and the risk of lateral condylar fractures and suspensory apparatus failure, our critical, potentially catastrophic injuries that we see in the horse. And Dr. Stover will cover that area. But I think it's important to realize that these studies do give us some information generally related to catastrophic injury. And as Rick has already pointed out, one of the important parts are the day-to-day training injuries, the injuries that don't require euthanasia but do require wastage. And this was a trend in that direction. Christine Verheyen is a veterinarian she did this work in Newmarket. She's based out of the Royal Vet College in London. There's a series of recently published papers, and some you have in the folder that was given to you, where they're looking at risk in training. They actually found some relationships to speed and distance as far as training is concerned, and it's an area where we definitely need to gather more epidemiologic data. And we need that epidemiologic data not to know our true incidence, but also to relate it to improvements in track surface, for instance. Manipulation of the musculoskeletal system, I've already alluded to this. In the interest of time, I won't get into it anymore, but we are trying to make the musculoskeletal system stronger. We know that the traumas and the problems are large when the horse goes into training. And can we strengthen that system, both bone and tendon and joint, I should say all of those tissues, earlier on in life? So lastly, it gets into early diagnosis of disease. I think you can appreciate from what I've shown you that it's critical for the prevention of the osteoarthritic process. It's equally important to recognize subchondral bone disease before it becomes a fracture or a catastrophic injury. And so this is an area that I'm sure we'll discuss more in the next 2 days, but the current status in the horse is that clinical examination and radiographic imaging are still the commonly used techniques for diagnosis of osteochondral disease, but there is increasing use of nuclear imaging, CT, MRI, and diagnostic ultrasound. Interestingly enough, there's usually a good correlation between the severity of the clinical signs, lameness and the joint filling we see, and the amount of damage or disease we find at arthroscopy. Obviously, not all horses get to arthroscopy, and so what can we do about diagnosing that early? I put this slide in because I think it's interesting. This is a paper that was published in '97 by Roy Altman, who's a very well-known human rheumatologist. There is no diagnostic test for OA in man. They find a lot of disparity between radiographs and injury, and so they have the same challenges. But there has been a focus on MRI and biomarkers in recent years in humans, and I'll talk about where we are with those here. So these are the options we have, or methods potentially available for diagnosing this early disease. Radiographs have been the standard, as I mentioned before. Computed and digital radiographs have certainly improved definition. And they're certainly still the gold standard. Radiographs are still the gold standard for diagnosing fractures and advanced osteoarthritis. When we've lost all our cartilage, we get decreased joint space. We get increased subchondral sclerosis or bone density. We see osteophytes. But there's a whole spectrum of disease before that we can't diagnose in that fashion. And this is just an example from a a comparison. This is just a radial carpal bone in the knee with some osteochondral disease. It's about to become a chip fragment. We can maybe discern a little bit of change on the radiograph, and I'll show you comparisons with CT and MRI shortly. So computed tomography, having increased use in the horse, both as a research and a clinical tool, and we can look at bone density and we can look at it in 3 dimensions. At the moment, as pictured there, we're doing these studies under anesthesia, which can still give us a lot of information, and in many times the anesthesia is worthwhile. This is sort of the same specimen I showed you with the radiograph, and this is what it looks like on a CT. We see lucency white means that we've got decreased bone, we've got disease going on in the bone, but look at the generalized increase in density over the 3rd carpal bone, which is an indication of that sclerosis, the change that we think is adaptive, but eventually probably becomes pathological. And we can look at these objectively. This is work from Chris Kowchak's PhD thesis. This is a hand-walked horse. This is an exercised horse on the treadmill. We've got a generalized increase in density, and we're starting to have breakdown of the bone. Now, this is long before you would recognize it on a radiograph, or long before it could become a condylar fracture in these areas where condylar fractures occur. So we can quantitate this increase in density, and we can put color maps on it for this change in density. And based on some work we did in New Zealand where we not only trained these foals, but we put them through 2- and 3-year-old years of racing with a professional trainer. We raced them with the hypothesis that we could decrease the rate of injury with this early exercise. And this is sort of some of the things that we're trying to look for with the CT. Is there a gradient difference here in density that sets off the process of condylar fractures? And Chris Riggs, an English veterinarian, did his work some years ago looking at pathologic specimens and providing good evidence that we do get this early change in the bone. We get differences in bone density before we get fracture. And so this is a potential means. Now, the way CT is going to get used in our industry is that it's got to be practical. We need to be able to do it standing. So we know we can diagnose this early bone change, but we need to make it practical. This is the portable CT, which we used in sedated foals in New Zealand in the study we did there. And this is 2 pictures from the only standing CT. It's made by the same company that developed the portable CT. And I was just there a couple of days ago in Dr. Francis de Brosa's clinic. This is using it under anesthesia, but this is actually imaging a fetlock standing. And so if we could just improve this technology to where we could use it as a screening tool in the same fashion that we use bone scanning, we could potentially have a means of predicting early disease that leads to fracture. MRI, of course, is here in the horse. It's a sensitive and specific imaging tool for both hard and soft tissues. We can look at bone change. This is looking at the same specimen we had before. But again, to be used as a screening tool, it's got to become practical. This is the system we have. It's a high field strength magnet. We have to anesthetize the horse. But we're certainly helping individual cases a lot. And the kind of change we're seeing is that early on, long before it shows up on radiographs, we're having so-called bone edema. And that's a general term used by imagers, but it does point out that we can see very early change in the subchondral bone of the fetlock joint, which is our biggest Achilles heel in the thoroughbred as well. And we can pick up cartilage erosion, we can pick up a subchondral defect. And this increased signal, we have various sequences that highlight certain tissues or change in certain tissues, but increased signal intensity in the subchondral bone represents fluid or granulation tissue back to the early pathologic process. We can also look at early change. This is a defect in a distal sesamoidean ligament, which is one of the ways that we can break down the suspensory apparatus and lead to a catastrophic injury. Again, this can be monitored with MRI. And this is just early change in the bone in a carpus. And we do have standing MRI, but at the moment it's pretty much limited to the foot. So I'll pass over ultrasound because it's not used a lot for the fetlock and the carpus, but we can diagnose quite a lot of the soft tissue injuries with ultrasound, and it's still the poor, the inexpensive equivalent of MRI. Nuclear scintigraphy has always been sensitive. This is work from horses on treadmills with very early subchondral bone disease, and so we do have scintigraphy, and if it's available, it can be used successfully as a screening tool. Synovial fluid examination, Rick led into this, mentioning it before our study, the study in California. The principle of biomarkers is that we get breakdown of these components, the proteoglycan and the collagen and the cartilage. We also get breakdown in the bone. These breakdown products go into the synovial fluid and then into the blood, and we have antibodies that can pick up and measure the levels of those breakdown products. This was the first study we did, and we showed that with about 70% predictability, we could demonstrate cartilage disease, early cartilage disease in equine joints. This was a study just with fluids and bloods from horses with chip fragments. But we could correlate the levels in the serum, not just in the synovial fluid, which makes it potentially quite convenient. We could quantitate and relate that amount, the levels of those biomarkers, to what was in the joint itself based on arthroscopy. We looked at serum biomarkers with OCD. This is an interesting study, but we were able to differentiate OCD lesions that were going to heal in foals from foals that were going to develop clinical disease. So the important part for our subject today is that we've got to do two things. First of all, differentiate between the effects of exercise and disease, and we've done this with various markers. This is serum glycosaminoglycan, which is a good marker of osteoarthritis in the horse. And this is just, we have to be able to differentiate. Markers change with exercise, but we have to differentiate disease from exercise. And osteocalcin is a marker in the bone. It's a synthetic marker, but we have been able to show that it changes with osteoarthritis and bone disease. So taking these various markers, this is another example of breakdown. This is breaking down the collagen. It led us into this study that was funded by the Grayson Jockey Club Research Foundation. And the hypothesis is that because of subchondral microdamage being an early event for fractures, if we could detect that, if we could detect microdamage, it has large implications. And we haven't got a home run in that we're at the stage where a single serum sample will predict a horse that's going to fracture, but it certainly gives us a lot more information in a horse that the trainer might be concerned about being at risk. And this has been presented at AAP and is at the moment in press as a result of this work. And so it does look, it looks good though for what we're going to do. There's newer techniques on the horizon such as gene chip microarray. We've done work with this with a small gene chip. Now that the equine genome is completely sequenced, it could lead to a major way of diagnosing early change. Last but not least, we still have to dwell on diagnostic arthroscopy. It is still the gold standard of looking in these joints and seeing the change, but unfortunately, not all horses get access to that. Thank you.